Hi all, my name is Dr. Arun Kumar K, ER consultant. He is Dr. Vivek, ER resident, and this is Jewel. She is a EMT working here. Welcome to the case scenarios in the ED. So we have this one patient here presented to the emergency department with history of seizures. Half an hour before, currently he is in altered sensorium. Right now we are going to the patient we have a doctor and a EMT nearby the patient. Now this is Baiju, the patient name. Now he seemed to be having an episode of active seizures. So we have Dr. Vivek here, he will be managing the case currently. Over to Vivek.
Okay sir, he is having active seizure, so we have to put him in recovery position. Make him in recovery position and we have to give a oral suction and we have to connect him to cardiac monitor and saturation probes.
So we have put the patient in the left lateral position, which is a recovery position, and then we'll try to tell Jewel to go for a oral suction because the patient might be having secretions, and put an airway device in the form of, first we put the oral mask in the form of a O2 mask, and then we'll either go for a OP or a NPA. Right.
Then 2 large bore IV cannulas will secure, preferably 18 gauge, and we have to give him, since it is an active seizure, we have to give him benzodiazepine. We are having midazolam, which is given as 0.1 milligram per kilogram weight.
Okay. So we have already given a shot of benzodiazepine, which is the first medication to be given in active seizures. So we are dealing with the patient with seizures. Currently we have put him in on an O2 mask and connect to the monitors, which is showing 100% saturation with a BP of 168 with a pulse rate of 70. So patient is currently sedated also because he was having active seizures. Right. So which is the first medication to be given for this patient?
First medication should be benzodiazepine, sir, in active seizures.
Okay. What's the dose of benzodiazepine which has been used?
Benzodiazepine, usual things are lorazepam and diazepam, sir. Lorazepam is 0.1 mg per kg, diazepam is also 0.1 mg per kg. These two are preferred in intravascular route. If intravascular route is not available, then intramuscular route is preferred. Okay. In such case, we can give midazolam also. Okay. Midazolam dose will be also 0.1 mg per kg we can give.
Okay. What about the pediatrics case?
In pediatrics, other options available will be parenteral diazepam we can give, sir. Dose will be same, sir. 0.1 milligram per kilogram of body weight.
Okay. Okay. Fine. So now we have put in the left lateral position. So what to do next then for this patient?
We have put him on left lateral position. Then we have to see whether seizure is aborted or still he is seizing, sir. Okay. So now then our reassessment start from the airway, breathing and circulation.
Okay, good.
Now airway is we have cleared with oral suctioning, and saturation is maintaining. Breathing, he haven't aspirated till now. We will auscultate and confirm it.
Okay.
And circulation BP is holding on good.
Okay.
Because of post-ictal phase or secondary to our medication, he will be having a low sensorium.
Okay.
Then we have to go for exposure part and sugar. We will check his GRBS. Sometimes hypoglycemia or hyperglycemia can also precipitate seizure.
Okay.
And here we have to check his temperature to rule out other infective causes of seizure.
Alright, so we started with management of the active reverting of seizures. We give him benzodiazepines. Now we are going to evaluate what could be the cause of seizures. So what the first medication was given was benzodiazepine. The first investigation to be done is random blood sugars. We checked this random blood sugar, it was found to be around 105, so it seems to be normal. The next investigation we are taking an ABG. Why? Because we need to see the lactate level, because we need to find out is it a true seizure or a pseudo seizure. Okay, fine, we've done an ABG also. What is next?
Arterial blood gas we will check, then we will go for history and evaluation, sir.
Okay.
In sample history we have to ask whether he is already a known patient who is on any medication.
Okay.
For seizure.
Okay.
Or then second thing is we have to be sure of his last meal. If it is a recent meal, there is chance that he can aspirate it.
Okay.
Then any skipping of medicines is there or not, we have to check.
Okay, what's the first drug of choice in terms of terminating seizure which you have? It is benzodiazepine.
Benzodiazepines.
Okay. What is the first anti-epileptic drug of choice?
Yes, sir. First anti-epileptics which we would prefer in emergency department is levetiracetam because of other side effects, sir.
Okay.
Which is having rest interaction and other hepatosafe and nephrosafe, sir.
Okay.
Orals preferred will be phosphonetine of 15 mg per kg. We will load it. Okay. And we can continue as fixed dose in further episodes.
Okay. So for an age group of this patient, he might be alcoholic. We never know about that, isn't it? So that could be the reason why we point more towards levetiracetam or Levipil, what you say in the ED, in terms of anti-epileptic agent of choice. Now we have a lot of other anti-epileptics like phenytoin, fosphenytoin, phenobarbital, etc., etc., etc. But then what we know is, what we safe is in the ED to be used for acute cases like either fosphenytoin, which can revert the seizure as early as possible, and the other advantage which can be given like within 30 minutes. Most of the antiepileptic agents which we use in the ED is like you have to give it over a period of 45 minutes. Fosphenytoin, which can be used over a period of 30 minutes. That is why it is the preferred choice mostly in children also, right? And to be on the side, like one of the most common things to be noted is the drug dosage. So all of a while, like what is the most common drug dosage used in the antiepileptic age group? Drugs as such.
Antiepileptics, levetiracetam, we can load with 15 to 20 mg per kg as bolus dose.
Okay.
And we can continue the same thing as BD dose, sir.
Okay.
If you are giving fosphenytoin, means fosphenytoin is also 15 mg per kg. Advantages, it can be given over 30 minutes. And phenytoin also can be tried, sir. These are the usual things which we would try in emergency department.
Okay. Now we have given the drug, you have reverted the seizures, you have provided the antiepileptic agent, you have seen the airway, you have seen the patency of the airway, you have taken ABG, seen the lactate levels, you wanted admission. But you never know what the patient is having a known seizure disorder as well as some other cause for the patient. So how do you evaluate the patient then? Will you go for imaging next or will you go for some other investigation next?
Sir, we will prefer imaging, sir.
Imaging. What imaging is the right choice for this?
If patient is also having temperature, then infective cause we have to see, sir. Yes. In such case, MRI brain with contrast we would prefer, sir.
Okay.
If not, if BP is, for example, if BP is high and patient had a seizure, then we would go for plain CT brain, NCCT brain, sir.
Okay. What about a trauma case? Alcoholic patient coming history of fall, maybe a road traffic accident, something is there. What could be the possible investigation in that case, sir?
In trauma patient, plain CT brain would be enough, sir, to look for bleed, to look for fractures impinging over brain parenchyma. Those are the two things which you are checking, sir. Plain CT brain is enough.
Okay. Now, the last part of the discussion. So this patient had a history of seizure. He came to the ED. Seizure was reverted. We went for imaging. This patient had a history of fever also. But the problem was the patient continued to have altered mentation in the ICU itself. What's the next investigation to be done in the ICU in case of altered, persistent loss of sensorium?
Then we have to check for his ammonia level and ultrasound we have to check, sir.
Excellent. Okay.
To look for the parenchyma changes in liver.
Okay.
Whether he is a CLD or not, we have to check for it, sir.
Yes. Okay. So we are looking at a case of possibly encephalopathy also, isn't it?
Yes.
Right. Anything else to be done
If
for
fever
this
is there, then we have to proceed with lumbar puncture to see for what is the organism in CSF fluid.
Excellent. Okay. Any role for EEG?
EEG we have to, if EEG 1 hour screen, EEG we have to check and we have to proceed for further continuous monitoring of EEG.
Exactly. So in terms of patient present seizure and continue to have altered sensory, in the ICU we will go for EEG because we have to rule out non-convulsive status epilepticus. Now that's a different case discussion. We'll go to another day. So this is the case which we are trying to present the ED, a case of status epilepticus present in the emergency department. This is how we manage in the ER. Thank you.